For this morning, it is my honour to open Let's Talk Clots and welcome two highly experienced and respected presenters with a very interesting session. MDT case studies and lower limb thrombosis, haematology and vascular surgery perspectives. Dr. Gill Lowe is a consultant haematologist specialising in haemostasis and thrombosis and has a specialist interest in problems of bleeding and thrombosis. Dr. Lowe trained in Cambridge, Manchester and Birmingham and is now based in University Hospital, Birmingham. Professor Alok Tiwari is presenting alongside Gill. He is a consultant vascular surgeon at the University Hospitals in Birmingham. He is a visiting professor of vascular surgery at Birmingham City University and an honorary associate professor at the University of Birmingham and the current training programme director for vascular surgery in the West Midlands. He has specialist interest in endovascular surgery and the management of the diabetic foot. He has more than 100 publications in all aspects of vascular surgery and works across West Midlands and working closely with the haematology team in dealing with patients with DVT. Welcome and thank you very much for being part of Let's Talk Clots. Enough of this introduction and let me pass over to Gill.
Thanks very much for the kind introduction, Jo, and for asking Alok and I to do this. It's an honour to be the inaugural session for a fantastic conference and a great initiative from Thrombosis UK. So what we wanted to deliver with this session really was just a taster of the kind of thing that we discuss day to day at work and the way that we need to work together in managing patients both acutely and chronically after DVT. So the way that we're going to work is we don't have that many slides, which is a good thing for this time in the morning. Alok is going to talk first, and then I will give a few slides of a haematology perspective and the kind of things that I'm thinking about when we're having our discussions. And then we should have plenty of time for Q&A at the end, so please do submit your Q&A. So without further ado, I will share the slides and we will get started. Okay, hopefully everybody can see them. So Alok, I'll pass over to you, and if you just let me know when you want me to move the slides along.
Thanks very much, Gill, and thank you for inviting me. My first slide, please, Gill. Right, so this is a patient that both Gill and I and a couple of our haematology colleagues, along with our interventional colleagues, managed a few years back. So a 50-year-old male he presented with the left painful thigh swelling and one episode of syncope. His only interesting history was that about 6 weeks before this, he'd had an ankle surgery, and then they'd put him in a cast, and he'd only had the cast removed 2 days before that. He'd actually been taking a blood thinner for a month, so which is what the orthopedic surgeons typically do. He presented to us with a 1-day history of this. Now, when you looked at him, you found that he had a warm, red, very tender, and a swollen left leg. And we made a provisional diagnosis of a DVT, and he was started on enoxaparin and with a view to plan to start warfarin at a later time. He had an ultrasound Doppler done, which showed that he had a DVT in the common femoral vein, the femoral vein and popliteal vein. And he also had a CT of his chest, and there was a small pulmonary embolism associated with this. Next slide, please. So the first thing, this is a picture of his DVT scan, and what it shows is that he has extensive below the groin deep vein thrombosis. So the choices then is what do we do? Do you try and treat this, or do you leave the body to take care of the clot while we thin the blood, and hopefully over time that the flow will be established by the collaterals? Next slide, please. However, despite his anticoagulation, by day 4, his leg was continuing to swell. So his body was basically not responding and not coping with this. So I came to see the patient along with our haematology colleagues, and we said, well, we'll change the low molecular weight heparin dosing. So sometimes you give once a day, but we find increasingly, and Gill may tell me completely the other way, that dividing the dose into 2 doses seems to work a lot better. And I think you get a bit more constant anticoagulation. So we did a CT venogram, which basically looks at the extent of the blood clot. And it shows the extensive DVT in the leg, but now it was extending above the groin into the external iliac vein. His leg was getting worse despite trying conservative treatment, so we decided to try and reduce this clot with a procedure called thrombolysis. Next slide, please. This is just a CT showing, I don't know, the arrow shows that there is extensive clot in that vein. And the way to look at this is to compare the other side where there is no clot. Next slide, please. So the way we do this thrombolysis is we approach the vein from behind the knee. So the patient actually has to lie, what I would call the Superman position, on their front. And then we puncture the vein behind the leg, and we trawl out the clot, and we start some blood thinning medication to try and dissolve the clot. This can sometimes take up to 24 to 36 hours to happen. The problem is that this can only be looked after either on high dependency unit or intensive care unit, or on a dedicated vascular ward. We were lucky at the Queen Elizabeth that we could look after these patients on a vascular ward, but many hospitals, you do not have these facilities, and they will have to compete to find an intensive care bed. Next slide, please. However, the thrombolysis worked brilliantly in this patient, and within 36 hours, you can actually see that the leg was of a normal looking color and size. And he had a repeat venogram, which is just injecting a bit of dye into the vein. And this showed no residual thrombosis. We then saw him at 1 month and 3 months. And again, we found no clot, and his symptoms had completely resolved. Next slide, please. And you can see from the clot picture before and to now, you can see that the vein has no clot in it, and it's actually flowing all the way up towards the groin and higher up. Next slide, please. And this is his scan. So if you remember what we showed before, that there was clot all the way down from the femoral vein, this is all now completely resolved. Next slide, please. So the thing to say before we discuss some of the problems with deep vein thrombosis was this gentleman had a very, very good result. It was a multidisciplinary approach on, should we treat this with blood thinners? Should we thrombolyze? And the reason we don't thrombolyze everyone is when you thrombolyze patients, you're causing the blood to become thin. There are patients who can have a stroke, can have a bleeding from being thrombolyzed, though we're much better at giving local thrombolysis. You can also throw off clots to the lungs and cause a pulmonary embolism. Thrombolysis is also painful. You can have patients, when the clot dissolves, it does move around and they do complain of pain. And the final thing is, because you're doing this over 24 to 36 hours, if you lose your access, so that's the tube inside the vein to allow you to thrombolyze, unfortunately, there are patients who have bled to death from this. So it's not for everyone. It needs deep thought behind it, basically a multidisciplinary approach. So just to talk a little bit about deep vein thrombosis. So what we presented there was an acute deep vein thrombosis, and they would normally present with left leg or calf swelling or a pain in calf. They may be short of breath because they've thrown a clot to their lungs, so pulmonary embolism. Or, as in the picture below, there is a condition called phlegmasia, where the clot is so extensive that the color of the leg changes. And this is usually an emergency. So I've only ever come across phlegmasia a couple of times in my lifetime. So it doesn't happen very often. And typically it is misdiagnosed as looking like someone who's got no blood supply and an arterial problem rather than a venous problem. So if you have a young patient with a warmish leg but very swollen and discolored, always think about phlegmasia rather than an arterial problem. What Gill and I tend to really see is what we call the chronic DVT patients, or the post-thrombotic syndrome. And these patients will typically present with a swollen leg. Eventually, they may have skin changes around the ankles. So these are called venous skin changes. They can either be eczema. In some patients, because of the poor problem with their veins, they can develop an ulcer, which are actually quite difficult to treat. Because the deep vein is damaged, you cannot reconstruct the deep veins, though people have tried it. So your management will differ compared to a normal patient with an ulcer. And a lot of it actually will involve compression bandaging. You may have heard of arterial claudication, which is when people get pain in their calf from walking. There is something called venous claudication, which is people get an aching in their legs and tiredness, and then that happens after walking. And again, the management, we try and use stockings if we can to try and help with this. There will be a smattering of patients who may need to have their deep venous system in the iliac side of things stented. And those are the cases that we tend to bring to our MDT and have an extensive discussion about it. And next slide, please. So if a patient came to me, usually they don't come directly to me. They usually come from our 3 haematology colleagues, the Queen Elizabeth. So what can you do? Well, you want to know that if you're going to treat anyone, do they actually have lifestyle limiting symptoms? So a lot of people use different questionnaires, and as you can see, no questionnaire is brilliant because otherwise we'd only be using one. So there's multiple questionnaires to see if it affects their lifestyle. So the Villalta is the one that's commonly used. And the next slide will show you the kind of questions we tend to ask. Thanks, Jill. So what are we asking them? We want to know if they have pain, cramps, heaviness, paresthesia, pruritus, which is itching, any swelling, any changes in their skin, redness, any kind of varicose veins, pain, or an ulcer. And obviously, the more severe the symptoms, the higher the Villalta score, and therefore we need to think about whether you will actually need treatment of your deep venous thrombosis or deep venous incompetence. Next slide, please. Then when it comes to investigations, so we tend to do a venous duplex scan, which is basically an ultrasound scan, or some people say, we've had the classic joke was, "Doctor, I'm not pregnant," when they try and scan the leg, because that's what it sounds like. We then move on to whether you would need a CT or an MR venogram. CT scan has radiation, but gives a slightly better results. MRI has no radiation, but takes much longer, and it's loud. We tend to move on to a venogram, which is puncturing the vein and injecting a dye directly, only in cases that we're planning to actually do an operation on, so which is stenting. Majority of the time with a venous duplex scan and a CT/MR venogram, we can actually tell the patient there is something we can do, or there isn't something we can do, and try and reassure them as best as we can. look for conservative management and discharge them. Next slide, please. The third slide basically shows MDT. These are complex patients. As you know, anyone with deep vein thrombosis have complex symptoms in their legs. Some of them have complex pain syndromes as well. And these are not easy things to treat. Just because we can get a good looking result on a procedure does not mean that their symptoms will get better. Every treatment we do has issues. So if we put a stent in, the stent can unfortunately clot off. So you need to be very careful on who you're putting a venous stenting in. So a lot of the time, the treatment is actually anticoagulation and just making sure the anticoagulation is appropriate. There's a lot of advice, as Gill was talking about earlier, she may talk about it. It's the psychological aspects of a deep vein thrombosis. I tend to prescribe a lot of stockings, and because these patients will have slightly misshapen legs, some of them need custom-made stockings, so you can't just buy over the counter. And I'm not going to discuss about venous stenting, but that is our final resort, where if someone has a blockage in their iliac vein, we can stick a stent in to improve the flow, but that has its own inherent risks. Next slide. I think it's yours now, Gill.
Yeah, that's over to me now. Thank you very much, Alok. So I'm just going to do a little bit on the kind of perspective that we would be giving as a haematologist. And I think for non-haematologists, we get a reputation for asking huge amounts of questions when we're contacted about a patient. But what I really want to get across to you is the reason for that is the detail of when the clot happened and how it happened is really important in the ongoing advice that we give about the anticoagulation. So as Alok has said, management of chronic symptoms after a DVT can be challenging, and we definitely need an MDT approach. And that includes the individual who's had the DVT, because everybody will have a different perspective about what they want, about what their view on long-term anticoagulation is, about how acceptable any chronic symptoms are to them, and how they fit into their lives and their occupation and their hobbies. And I think contextualizing like that is really important in looking after that person to the best of our abilities. And I think we've already made the point that surgical or radiological intervention isn't a cure, and that if we do go down that line, it's really important to have effective anticoagulation afterwards. So it can give excellent results, but people need to understand that if they have that approach, it's not going to stop the need for medication afterwards, which I think is a common misconception, that having intervention will mean that no long-term medications are needed. So this is a fictitious case history, but it's based on the kind of thing that we see all the time. So the typical case that we would manage in terms of the chronic side of DVT, Alok presented an acute DVT earlier, but this would be somebody who'd had a large, what we call proximal DVT, meaning that it's happened close to the center of the body, so in the groin veins or in what we would call the iliac vessels, the bigger vessels at the top of the leg. And that typically would have presented with pain and leg swelling, and that individual would go on anticoagulation. And again, Alok mentioned the low molecular weight heparin dosing. Our standard for inpatient management now is to give a twice daily low molecular weight heparin dose. For outpatient management, we will sometimes use once daily, but the twice daily regime is designed to give a better trough, meaning the lowest level of anticoagulation is higher than it would be with a once daily strategy. And then our practice is to see these patients in thrombosis clinic, ideally at 3 months after the event. But unfortunately, because of problems that we have within the NHS with resourcing, it's often later than that. And that is a problem that we acknowledge, and something that patients often feed back to us about, that they felt anxious waiting for that appointment, coming back to the mental health side of things. And at that appointment, we have a few different things to decide. So the first thing is about what we need to do about anticoagulation. The second thing is about any ongoing symptoms, and whether we need to involve colleagues in management of that. So if I saw somebody like this who had significant ongoing symptoms at this stage, I would talk to them about what anticoagulant they were on and how we can optimize that. And then I would have a discussion with Alok or my colleagues in radiology about whether they could see the patients as well and give some advice about whether there's anything from a surgical perspective that they think that they could offer. And if we went on to do an intervention, we would see these patients quickly afterwards and make sure that we were closely monitoring their anticoagulation. And a lot of that hard work is actually done by the anticoagulant specialist nurses rather than our team as consultants. And I know that there's a large number of anticoagulant CNSs registered today, and I'm sure this sort of history will be very familiar to you. And we've talked a bit already about the potential further complications that we might see. So if somebody has a venous stent inserted and their anticoagulation is suboptimal, you can get stent occlusion, which then worsens the symptoms in the leg. There is always a chance of further DVTs. And then the other thing that I would think about in terms of longer term follow-up is this patient going to have any changes in their circumstance which might further increase the thrombosis risk? So specifically in younger women, pregnancy is something that we think about, and we like to plan and have a pre-pregnancy counselling appointment to discuss how we would manage pregnancy and what we would do on receipt of a positive pregnancy test. And another example of a challenge to thrombotic risk in the future would be if the individual needed to go on to have surgery, where we would know there's an additional risk superimposed on their background risk. So when we see somebody in our thrombosis clinic review, there's a number of things that we're trying to find. So the circumstances of the DVT are really important, and I think patients are often surprised by how much we ask them about that. But the reason for that is that we're trying to work out, was this a provoked or an unprovoked event? And it sounds very straightforward to make that categorization, but there are all the shades of grey, and actually there are some factors which we might say are minor provoking factors. And there is ultimately a judgment in making that call. And I think talking to patients about how you're deciding that is really important, and explaining what the degree of provocation has been. We would go through it with the medications and diagnoses, lifestyle factors. I've had patients on anticoagulation who've had particular hobbies where we've needed to discuss how we're going to manage that, and pros and cons. We've had some people who are professional sports people where being on anticoagulation may have an impact. So knowing about that individual is really important. Caregiving responsibilities I've listed really to do with the monitoring that we need for the anticoagulation. So if you're on a vitamin K antagonist, most commonly warfarin, but you have dependents or you have a very busy job, attending for monitoring is not going to be that easy, and we need to think about that. We would ask about family history in terms of whether there's anything about this individual overall that seems to predispose them to thrombosis. And then we would talk a bit about how often they might forget their medications. So is it better for them to be on a once or twice daily anticoagulant? And what can we do to help with that ability to remember them? And often that's very simple interventions like using a mobile phone alarm or linking taking the medication to a particular other task in the day. But I think thinking about those practical things is important. And then finally, we would normally finish that appointment by talking about investigations. So one of the things we might think about in unprovoked DVT is whether we screen for antiphospholipid syndrome. And we would make a recommendation about duration of anticoagulation, which is typically either limited duration or lifelong. That's the decision that we're normally making. We've talked about this already, that the practical issues are often the most limiting thing. So remembering to take it, sometimes the need to take it for food. Issues in women's health is a massive area. We could probably do a talk on that on its own. So women who are on anticoagulation have an increased risk of their periods becoming heavier when they're on it. That risk is higher for some anticoagulants than others. And then people become anemic and feel unwell as a result of that. So management of periods on anticoagulation is a huge area, and I'm sure that's something that Thrombosis UK hear lots about otherwise. Some people are very worried about the bleeding risk of being on anticoagulants, and that's an important thing to discuss. Generally, the overall bleeding risk is low, but we need to talk to people about how they should manage things if they are involved in trauma or if they're due surgery. And then finally, sometimes obtaining prescriptions is a concern. So we would make it clear about whose responsibility it is to be giving the ongoing prescriptions, and give the patients a contact number if they're having any issues obtaining prescriptions. We can sometimes check blood levels for non-warfarin anticoagulants, so the direct oral anticoagulants or low molecular weight heparins, but that's not a standard test. So we would typically do that where there were extenuating circumstances, and that might be somebody whose body weight is an extreme of normal, somebody who's got problems with their kidney function, or somebody who's having recurrent thromboses, so what we would call breakthrough events whilst they're already on anticoagulation. This is just a picture talking about a venous stenting in venous thromboembolism. This is from a paper by Karen Breen, who's a haematologist in London who does a huge amount of work with DVT and works with her vascular surgery team as well. So if anybody wants a reference, I would recommend this as a good educational resource. And it talks about the acute intervention, which Alok mentioned before, the thrombolysis, and then management of chronic DVT, again with the combination of stockings, anticoagulation and a stent. And I've included an illustration of a stent for anyone who's not seen them. So this is the sort of appearance we might have, like a mesh device that sits inside the vessel. And then just to finish, one of the common issues that we have is how we approach anticoagulation after somebody's had a venous stent and what we should use. And I think the conclusion for this really is that we really don't have very much evidence about what to choose. So most of the studies in this area have used either unfractionated heparin, which is obviously a very old-fashioned medication now, low molecular weight heparin, or the vitamin K antagonists. But that's because some of the studies are from longer ago when we didn't use the direct oral anticoagulants as much. So generally, we will use a low molecular weight heparin for a short time afterwards and then think about going back on a direct oral anticoagulant. But this is an area where we definitely need more evidence and more research, and we need discussion within our team and with the patients about what we're going to do. I've already mentioned pregnancy. So if a patient who has a venous stent becomes pregnant, our general approach would be to convert them to a high dose of low molecular weight heparin on receipt of a positive pregnancy test, and to follow them carefully throughout pregnancy. And if we do need to escalate anticoagulation, so if somebody's having events after stent insertion, or if there's a concern clinically, then the broad options are either a change of drug, so to try a different medication, for people who are already on warfarin to change their INR target. But what I would say about that is that we know as INR targets go up, it's harder to keep people in range. And obviously, as you increase the INR target, there is an increased risk of bleeding if people have higher than their therapeutic range INRs. And then occasionally, if we have someone on warfarin already with a high INR target who's having recurrent events, we would think about adding what we call an antiplatelet. So that's typically aspirin or clopidogrel into the anticoagulant, because that works in a slightly different way to reduce the overall thrombotic potential of the blood. But again, we have to weigh up the fact that that does increase bleeding risk. So that's the end of our slides. Thank you very much for listening. We've got plenty of time left and we're very happy to take some questions and answers. I'll stop sharing the slides so that I can see the Q&A, because I did see that there was some Q&A coming through.
Shall I ask the questions?
Yeah, that's fine, yeah.
I'll make it easy for you. So what is your anticoagulant of choice after stenting, and what is your duration of therapeutic anticoagulation, Gill?
Yeah, so I think we've just touched on that, haven't we? And I think our general approach, you can correct me if you think I'm wrong, Alok, is that we tend to use low molecular weight heparin for probably 3 to 6 months. And then at that point, if the patient's symptoms were stable and their preference was to be on a direct oral anticoagulant, we would change back at that stage. There is a little bit of evidence about using an antiplatelet in the time immediately after stent insertion as well. So if we didn't perceive the patient to have a high bleeding risk, we may add that in at least for the first 6 months as well, if there was no other contraindication. I think, I mean, my experience in terms of duration is skewed because I obviously tend to see the people who have more problems. So I have had very few patients who have stopped after venous stent insertion because there's normally an underlying risk, or they've had an unprovoked event in the first place. That would mean we would be keeping them on lifelong anticoagulation anyway. I think in very rare circumstances where there'd been a provoked event and then a stent was inserted after that, we would then have to discuss whether it could stop. I'm aware of evidence where when stents are inserted for other reasons, you can stop, but I think I'd feel very apprehensive about stopping before 12 months in that instance.
Yeah, I mean, it's interesting when you speak to patients and you go, well, you know, we could stop your anticoagulation, and you'd be, the jaw drops and patients are going, no, we're quite happy. Our symptoms are so much better and we're quite happy to take blood thinners. And Gill and I see a lot of axillary vein thrombosis as well. And some of them have to do with the first rib. And again, some people would rather continue with anticoagulation or rather than having an operation to remove their first rib. So I think it's so much about patient choice, but at least 6 to 12 months is the minimum, and an antiplatelet is what we tend to use. But as Gill said, it's not a full evidence-based approach because there is no full evidence for this. Right, second question for you, Gill. It's all about you. We sometimes see patients with recurrence of thrombosis after thrombolysis. We offer increased dose of low molecular weight heparin with anti-10A monitoring, checking for thrombophilia. Do you have a different approach?
No, I think I would agree with that. So especially early rethrombosis, I would be looking at what had happened on the ward in that time. You know, were the anticoagulants administered on time? Were there any mechanical factors associated with the procedure that Alok and colleagues thought might be contributing? But yes, I would definitely dose increase and then do an anti-10A early. So with anti-10As, we generally would need to wait for 3 doses of the amended regime before checking one, but I would be aiming to do it at that stage. I think thrombophilia testing is really controversial, and again, that's sort of a separate talk on its own. I wouldn't necessarily do thrombophilia testing in everyone. I would want to know about the circumstances. If there was a clear provoking factor, I probably wouldn't. But if it was somebody with an unprovoked event and a significant family history where I thought it might make a difference to the recommendation we gave about anticoagulation in the long term, then we'd consider it. So with thrombophilia testing for inherited thrombophilias, our approach is that all of those requests come through a laboratory MDT that's attended by a senior biomedical scientist and one of our consultant team, and we vet those requests before the test is done, because of the fact that if they're done unselectedly, it can cause a lot of concern and confusion. And quite often we will bring the patients to clinic to have that discussion about whether we do the test, because we know if we do them acutely, the results can be affected by having a large acute clot. Some of the protein-based inherited thrombophilia screening can be affected. So I've been waffly about the thrombophilia question. I think the bottom line with that is that I would consider it, but I wouldn't do it in everyone.
And then what is your
Sorry, Alok, I think your connection just lost for a second. I don't know if that was just me, but I think you were asking the question about the approach to incidental finding of DVT with collaterals. Is that right?
Yes.
So with incidental DVT/PE, that is a tricky area. So incidental PEs, the guidance now is that we treat them as we would any new event. Incidental DVT, which is chronic and there's evidence of recanalization, we have had some cases where we haven't given anticoagulation because when we've talked to the patients, they, for example, may have had a hospital admission many months ago where we think the clot may have happened in that time, and they are out of the window where we would have given anticoagulation and then stopped it. So I think the approach to anticoagulate and chronic DVT really needs a discussion. I would generally always err on the side of caution if I have any uncertainty about whether there's a clear explanation or whether we would have still been giving anticoagulation at this point anyway, then I would give it. But we have had some patients who've had very few symptoms, you know, and have had a clear explanation who haven't wanted long term, and we've accepted that approach.
Yeah, I mean, we occasionally find in our vascular clinics in patients with varicose veins, because everyone gets a venous duplex scan, and you find they've had evidence of DVT or usually with reflux, so they're recanalized. These patients, apart from refusing to do their vein surgery, we don't do anything else. And actually, a lot of them, you will find is a lot of them may have had very severe leg swelling when they were pregnant. So that might have been a DVT, which was never unrecognized. Or they may have had, you know, they were very keen sportsmen, break their leg, and no one ever actually looked at why their legs were swollen. And we find that. Right. So we have a question about, can you see it? Or do you
Yes, I can. So 6 months of low molecular weight heparin is a long time to ask someone to self-inject. What's better about low molecular weight heparin than an anti-10A acting DOAC? Why not switch to a DOAC earlier at the outset? Excellent question. These are the sort of practical discussions that we have all the time. I don't think there's anything better about one over the other. I think it's purely, as we often see in medicine, a historical approach, and the fact that we don't have lots of evidence of using the DOACs after stent insertion, but it's an area where we definitely need more attention. And I have quite a practical approach that if somebody's not going to take the anticoagulant that you prescribe them, I'd rather that we have them on something that is acceptable to them and that they will take. So if I had someone in that situation who was struggling with the low molecular weight heparin, and again, it's normally our clinical nurse specialist colleagues who come to us with this feedback or who get this information, then we would talk about the sorts of case-by-case adjustment to anticoagulation. But I completely accept your point, and I think that's something where there is significant regional and trust variation in practice because of the lack of clear evidence, really.
Okay, so we have a question of how would you approach superficial thrombophlebitis in terms of anticoagulation type and duration? All I would say from a vascular point of view is it depends on who you see. So one of the things you find is if you turn up with some thrombophlebitis to a vascular surgeon, they would just scan your vein to see if you need your veins treated for the future, and they probably wouldn't do any more than that. If you turn up to acute medical unit, Jill will know what the answer to this is, because we're having discussions about rewriting the protocol to make it a bit easier, following the latest guidelines from some of the societies. So over to you, Jill.
Yeah, so again, great question. I think there's generally a move in superficial thrombophlebitis to considering oral anticoagulation more. So historically, it was treated topically or with surgical intervention. We have certain criteria now in terms of whether we offer anticoagulation, which are to do with the amount of superficial thrombophlebitis that there is. So if you measure it, how much of the vein is affected, and then where it is in relation to the saphenofemoral junction, which is an anatomical site. So there are national guidelines about those criteria, and people who meet the criteria are normally offered at least 6 weeks of anticoagulation. But I've got a number of patients who've had recurrent superficial thrombophlebitis who come to clinic, and we often, in those patients, if I can't find a clear reason, I would consider doing CT imaging to look for an underlying cause, because there can be an association with malignancy. And I would do blood tests to look for any other factors. But if we can't find anything, I have offered those people long-term prophylactic anticoagulation, because the symptoms can be very distressing, especially if there's not a surgical option.
And then probably the final question, because I know we both have to go, is do you see patients with a history of recurrent thrombosis then go on and develop arterial disease but no atherosclerosis? I'm not sure what MPN and APS stands for.
Myeloproliferative neoplasm and antiphospholipid syndrome.
Yeah, that's why we need you here. What would be the anticoagulation of choice? Warfarin over DOACs, add antiplatelets. I would say it's after a very long time. If I switch it around, I've actually seen a patient with atherosclerosis who developed a DVT, which is a very rare thing for me to see. Doesn't seem to happen very commonly, but you might see it, Gill.
Yeah, so we definitely do see this, which I'm sure most haematologists do, that people will have venous events and then have arterial ones, and they don't have other risk factors for arterial events. So in that situation, it would be prompting me to reconsider any underlying diagnosis. And yes, definitely MPN and APS would be two of the options that we would think about. Again, I would think about malignancy, or about some of the inherited thrombophilias in that situation. And I think choice of anticoagulant really depends on what results you get back. So with antiphospholipid syndrome, there's emerging evidence that persistent lupus anticoagulant positivity confers a high risk of ongoing events. And especially if those patients have had arterial events, I would recommend a change to warfarin. And that's quite a regular discussion that I have. So I think if somebody's getting new events, then that normally would prompt me to think of at least a change in dose, if not a change in agent. And again, it's a historical thing that there is more evidence normally for the vitamin K antagonists in these people who have a high risk because of either an underlying inherited or acquired thrombophilia.
Okay, definitely the final question. So do you have times when you would suggest antiplatelets after stent and thrombolysis? So as a general rule for antiplatelets is, if we're planning to do a stenting, we will probably start the antiplatelet at least a week before to allow time for it to stabilize. Or if we're doing it acutely, I would just give them a stat dose of 300 milligrams of aspirin, because aspirin seems to be the one that most people use rather than clopidogrel for venous stenting. Gill?
Yeah, I agree. I think our practice has generally been that when we see the patient after stent and we talk to them about the bleeding risk on a combination, and if there's not a contraindication like asthma or any other sort of medical reason, then we would usually add aspirin. The bleeding risk of adding aspirin to anticoagulation is probably slightly lower than adding clopidogrel, so that's another factor as well.
Yes, I think so. If someone wants it, but we would probably give them an oral anticoagulant rather than 6 weeks of low molecular weight heparin, was the final question. So I think, Joe, do you want to come back in, or?
Yeah, I'd just like to say thank you very much. I mean, for the early morning, tremendous questions, but a fantastic presentation from you both as well. Thank you very much. Thank you to the audience as well. I know sometimes it can be a bit off-putting putting your questions in, but they were tremendous questions and great discussion.